Ngayon, napag-usapan natin dati pa na ang lahat ng virus, nag-mutate yan all that time. Kaya kung scientist yan, hindi nyo sasabihin na they just found out that the virus has been mutating. Alam niya na nag-mutate all that time. Pagkatapos sasabihin passively become more contagious, alam natin na in the same epidemic, ang chances are it will become less and less virulent.
According to the available evidence, people with diabetes do not have a higher susceptibility to SARS-CoV-2 infection. My topic is about treatment of diabetes in patients with COVID-19. This pandemic mostly are noted to be in hyperglycemia.
I haven't seen much of hypoglycemia. It's really more of hyper.
Recommend discontinuation of the non-insulin medication and initiation of insulin therapy for patients with diabetes or newly recognized hyperglycemia at the time of hospital admission. Insulin treatment is still the first choice if diabetes is combined with severe infection.
Personally, natuto ulit akong gumamit ng mga human insulin.
Kaya, pagka merong comorbidities, mas severe ang nakikita pag nagkaroon ng infection. Makikita ninyo rin at dapat ma-realize natin na with these kinds of defenses, hindi tayo pinabayaan ni Lord ng Panginoon. Be strong and courageous. Do not be afraid or terrified because of them. For the Lord your God goes with you.
Can you just text me? I'm in a webinar eh. Sige, okay.
Hello. Hello, good evening. So, on behalf of our President, Dr. Richard Elwin Fernando, I would like to welcome you all to our 4th series of the PSD Select. So, we're already on our week 4. And this would be our program. So to start, let's have our prayer. So let us pray and put ourselves in the presence of God. Lord, give us strength to face the day ahead. courage as we approach each hurting bed, wisdom when with every word we speak, and patience as we comfort the weak and the sick. Guide our thoughts so that we walk in love and peace, and with gratitude stamped in our heart. You know what we need, and we are sure you will provide, so that as in Cana of Galilee, we may return to joy and to feasting after this time of trial. God bless our activity, our speakers and participants. In Jesus' name, amen. Okay, good evening, everyone. So I would like again to thank you all for coming, and we would like to thank also our sponsors for this night from Merck Incorporated. So from Merck Incorporated, the makers of Glucophage XR 500, 750 milligram, and 1 gram. And also Glucovance 250 per 5 milligram and 500 per 5 milligram. So to proceed, next, before we proceed with the discussion, these are the participants who have won prizes. So sa next slide, makikita natin kung ano yung mga napanalunan nito mga nag-participate na to. So these are the list of the participants who will receive their PPE from PSD. Balik muna tayo para makita nila yung mga pangalan nila. Okay, so we have Dr. Hipolito. Yung next set. Yeah. Dr. Toledo, Dr. Pasaporte, Dr. Carinal, Dr. Pabua, Dr. Fajardo, Dr. Abdurrahman, Dr. Rafi Cruz, Dr. Elinita Santos, Dr. Liza Marie Pastan, Dr. Arima Tan, Dr. Tony Chua, Dr. Grace de los Santos, and Dr. Sobrepeña, Dr. Bunyi, and Dr. Roman Wabel and Ms. Leiden Florido will each receive a PPE. And the other prize, sa next slide, these are the doctors who will receive their alcohol dispensers, Dr. Akailaw, Dr. De La Vega Torrio, Dr. Jolina Santos, Dr. Ben Sinoro, Dr. Grace Ronan, Dr. Gloria Craig, Dr. Lou Reyes Gonzalez, Dr. Frances Quebec, Dr. Nenita Tan, Dr. Alvin Andaya, Dr. Cynthia Sanchez, Dr. Wewet Libed, Dr. Magia Agnes Soriano, Dr. Joji Muli Marcos, and Dr. Nines Bautista. So congratulations to each and every one. And in the succeeding series, we will still have some more prizes to be given away. So just sit back and relax, and we'll continue. And next. So again, we would like to thank our sponsor for this evening, Merck Incorporated, for our Pharma CME grant. So let's hear a video clip from them.
Good evening, dear doctors. I am Janessa Marcelino, the Assistant Product Manager of Diabetes Franchise of Merck. First of all, on behalf of Merck, we would like to thank you for having us and being part of this event, the PSD Special Edition Lectures. Doctors, for more than 352 years, curiosity has been driving Merck to deliver excellence to its patients and customers. In fact, Dr. Glucophage XR has more than 60 years of clinical experience and innovation in the management of prediabetes and type 2 diabetes. I would like also to highlight that Glucophage XR is equipped with the social diffusion system. This is a unique tablet technology that allows for gradual release gradual and prolonged release of metformin, making it truly once-daily dosing and improving your patient's adherence and compliance. For combination therapy, we have glucovans. It's the powerful combination of metformin plus glibenclamide. Glucophage XR is available at 500, 750, and 1 gram, and Glucovans is available in 500 over 2.5 and 500 over 5. Again, doctors, we thank you for your support and we hope that you keep safe all the time. Before I leave this presentation, I would like to share with you the journey of Glucophage XR, the 60 seconds of 60 years video. Please watch po.
Thank you very much, Ms. Jen Marcelino, the Assistant Product Manager of Merck Incorporated, the makers of Glucovage and Glucovans. So again, this is the Philippine Society of Diabetology Special Edition lectures on COVID-19 and diabetes. So next slide, we will have the next slide. The objectives of this is we will discuss the COVID-19 issues associated with diabetes and COVID-19 and some concerns and cases on people with diabetes. Next. So this is our program. We will be watching the presentation of Dr. Fernando on what are the host defenses versus diabetes versus viruses, and followed by Dr. Marcy Cruz's presentation on the treatment of COVID-19 in patients with diabetes. Last time, di ba, ang napag-usapan natin yung mga diabetes na nagkaroon ng COVID-19. Now, it's the other way around, yung treatment of COVID-19 in patients with diabetes. Okay? So, I'll turn you over to Dr. Fatma Chu for the introduction of our first speaker.
Good evening, Danny. Good evening, everyone.
Thank you. Good evening.
So our first speaker, as always, to talk about the basics of COVID is Dr. Elwin Fernando. He is not here with us. I think the lecture that he's going to present tonight has been presented last week. We will replay it tonight because it is very interesting, and I'm sure marami tayong na-miss kasi medyo mas complicated. Medyo complicated yung topic. So again, let us welcome Dr. Elwin Fernando.
Yung susunod na slide ko, no? Siguro nakita nyo na sa inyong mga internet, no? Kahapon lang lumabas yan eh. Pero kung nakikinig kayo sa kwentuhan natin, maintindihan nyo kung ano sinasabi niyan. Pero nyo, med page yan. Pinakita nila sa internet. At kung nakikita nyo yung yung aking pointer, wala. Nasaan yung pointer ko? Ayun, no? Sabi dito, no? Scientists analyzed a large collection of genetic sequences of SARS-CoV-2 and found that the virus has been mutating and possibly become more contagious according to a paper released before peer review. Ngayon, napag-usapan natin dati pa na ang lahat ng virus, nag-mutate yan all that time. Kaya kung scientist yan, hindi niyo sasabihin na they just found out that the virus has been mutating. Alam niya na nag-mutate all the time. Pagkatapos sasabihin, possibly become more contagious, alam natin na in the same epidemic, ang chances are it will become less and less virulent para maging para tumagal ang buhay ng virus at saka yung host. Pero isa pang yung term na contagious, medyo ang hirap din i-explain na contagious, yung nakakahawa siya. No? Kaya ibig niya sabihin, hindi na yung ACE2 receptor ang yung mutation niya o naging dalawa na ang possible na functional receptor niya. Walang virus na kung alam na dalawang functional receptor. Isa lang yan talaga eh. At saka yung pagiging contagious, kadalasan it's because of the habits of the host. Ayaw mag-mask ng lahat ng tao eh. Kaya kumakalat. Pero yung huling sinabi dito na medyo nakaka-question is released before peer review. Hindi ginagawa ng mga medical journals yan. It's either after peer review, they reject or they accept a literature. Pero ito, na-release before peer review, talagang, ito mga Washington Post, talagang mga journalist talaga eh. Mahilig sila magbigay ng mga ganyan eh, na hindi pa sigurado. No? And number 2, na siguro nag-strike sa akin dito sa nilabas nila, yung sinasabi dito na the FDA authorized AssureText Rapid SARS-CoV-2 antibody test for point of care use. Antibody test for point of care use. Yung gagawa niyan. Yung antibody test para malaman mo kung nagkaroon na siya o hindi pa nagkaroon ng COVID-19 or infection, no? Pero kung malaman mo kung gagamutin mo yung individual o hindi, kailangan mo antigen test, hindi antibody test. Kaya kung minsan, kung magiging critical kayo, maintindihan nyo yung mga sinasabi sa pinapost. Pero ano yan ha? Med page yan. O ngayon, at least, you will now be critical also with what you are reading. No? Ayan. Hingi ako ng 30 minutes less than 30 minutes para sagutin natin yung bagong tanong ni Nadia Betis. No? Kwentuhan style pa rin. Ha? Dati, first time, what is SARS-CoV-2? Ang sinagot natin. Sumunod, ano yung life cycle ng virus na yan? Ngayon, ang pag-usapan natin host defenses. Kasi karamihan tayo, ang feeling natin sitting duck na lang tayo sa mga viruses eh. Wala tayong panlaban sa viruses, no? Ganyan din siguro ang feeling ng Archbishop na sinabi, basta na hindi na daw kinakailangan mag-face mask at ayaw daw ng Panginoon na lumalatayo tayo sa kanya. Ito, no? Dito sa 30 minutes na to, 20 or 30 minutes na to, sana maintindihan nyo, no, na di sa mga nangyayari na to, hindi naman tayo ilalayo sa Panginoon eh. Pinapakita na nga ng science na napakalapit sa atin ang Panginoon. Nung creator natin, napakalapit sa atin at iisa-isahin natin yan. Yung kaya lang natin dito sa 20 or 30 minutes. Doon nga sa sa book na Deuteronomy. Meron din yan sa Deuteronomy din sa sa book ng mga Hudyo. Meron din sa Quran ng Deuteronomy. Sabi diyan, be strong and courageous. Do not be afraid or terrified because of them, for the Lord your God goes with you. Laging nakasama ang Panginoon. Nandiyan yan. Makikita nyo, levels of host defenses. Maraming levels yan. Ang isang level is physical barriers. Ang physical barriers level, non-specific yan. Kahit anong virus, bacteria, fungi, toxin, yan yung mga anatomical barriers against these invaders. They are continuous. Nandyan siya lagi. Yan yung ating skin, yung mga peklat, o saliva, mucus, tears, stomach, defensins, natural microbial flora. Pag-usapan natin ng konti mamaya yan. Pero nevertheless, pag masyadong marami yung virus, yung iba nakakalusot dyan sa physical barriers at umaabot doon sa second barrier na tinatawag na intrinsic defense. Yung intrinsic defense, usually, walang kinalaman gaano sa immune system yan. Pero lagi siyang present. Non-specific yan. Immediate ang kanyang response because it is always there. Yung intrinsic immunity, yan yung mga interferons, autophagy, apoptosis. Sa ibang species may tinatawag na microRNAs at saka CRISPRs. Huwag nyo may memoryahin yung mga yan. Pero pag-usapan natin in a way na overview na natin mamaya. No? Kita nyo, binigyan tayo ni Lord ng physical barriers. Ibig sabihin, lagi siyang may padala sa atin against parasites. Pagkatapos, hindi lang yun. Binigyan din tayo ng intrinsic defense. No? Pero yung mga virus, magagaling mag-shortcut o mag-overtake. Pwedeng makalusot pa rin yan pag marami yan. Meron pa rin susunod na defense yan. Ang tinatawag sa susunod na defense ay innate immunity or innate defense. Yung innate immunity, meron na yung konting participation ng immune system. Kaya itong innate intrinsic immunity, may konting, at saka yung tinatawag na susunod na barrier, may konting ma-overlap yan. Yung innate immunity, yung defense na yan, no, it is non-specific. Yung tatlong barriers na yan, non-specific yan. Whether bacteria, whether virus, toxin, non-specific sila. Yung intrinsic, napakabilis dumating. Pero yung innate immunity, it takes a few minutes. Like for example, no, pag may pumasok na virus, nandyan lagi yung physical barriers, lagi nandyan yan. Pagkatapos nung nakalusot sa physical barriers, nandyan yung intrinsic immunity, lagi pa rin nandyan yan. Pero pag nakalusot pa rin siya, ma-activate ngayon yung innate immunity after a few minutes to a few hours. Yan na yun, yung mga natural killer cells, yung complement system, cascade, antigen-presenting cells, mga neutrophils, at saka yung production of cytokines. They come after a few minutes to a few hours. Different levels of protection. Always with us yung mga yan. Kaya kung sasabihin, lumalayo sa atin ng Panginoon. Kahit saan tayo pumunta, meron siyang semblance ng binibigay niya sa atin. No? Ngayon, pwede pa rin makalusot yan ng virus. Kasi yung virus, yan ay produkto ng matagal na pag-mutated. Kaya, kahit pa paano, nalulusutan niya one barrier after another through time. Pero pag nakalusot siya sa innate immunity, merong last barrier na tinatawag na adaptive immunity. Konti lang pag-usapan natin sa adaptive immunity ngayong gabi. Siguro pag-usapan natin yan more in detail pag ang pinag-usapan natin ay vaccines. Kasi mga vaccines, nakatuon kadalasan yan sa adaptive immunity. Adaptive immunity is something that the immune system learns. Kaya nga sa vaccine, di ba? Nagbibigay ka ng vaccine para malaman niya na merong danger pag dumating yung ganong klaseng antigen. This takes hours to days, sometimes weeks or months, yung adaptive immunity. At dyan ang nagpa-participate yung T lymphocytes, yung B lymphocytes. Nakatira yan sa iba't ibang places, nakatago sa iba't ibang parte ng ating katawan. Ngayon, pagkas yung mga bata ang pag-uusapan, usually, very, very active yung non-specific defenses nila. Yung mga bata, mga teenagers, very active yung kanilang yung kanilang mga barriers sa intrinsic, innate. Pero through time, dahil sa dumadating yung exposure sa ibang klaseng bacteria at enzymes, unti-unting nagde-develop yung adaptive immunity. Kaya pagka adult na tayo, matanda na, ang talagang best level natin is adaptive immunity kasi through time, nakita na natin lahat ng mga antigens, lahat ng mga viruses. Hopefully, nakita na natin at natutuhan na ng ating immune system. In such a way, no, pagka tayo ay unhealthy, yung lahat ng barriers na yan, nagwi-weaken. Whether physical barriers, intrinsic, innate, lahat yan nagwi-weaken when we are not healthy. Eh, siguro yung mga smokers, nababawasan yan. Mucus, yung ciliation, nawawala yan sa respiratory tract pagka smoker. Kaya sa diabetes, naapektuhan din yan. Yung glycation, yung production of radical oxygen species. In hypertension, nababawasan din siya. Obesity, which is a chronic inflammatory state, naapektuhan din yung intrinsic, innate, and adaptive immunity to a point. Kaya, pagka merong comorbidities, mas severe ang nakikita pag nagkaroon ng infection. Palagay ko, hindi lang SARS-CoV-2 viral infection or COVID-19. Lahat halos infection. But at the same time, makikita rin at dapat ma-realize natin na with these kinds of defenses, hindi tayo pinabayaan ni Lord ng Panginoon. Meron siyang pabaon sa atin na hindi natin dapat kalimutan. Nilalapit niya tayo sa Kanya. Hindi nilalayo. Kasi ang feeling ni Father, dahil sa alam natin itong gantong klaseng science, nilalayo natin yung mga tao sa Panginoon. Hindi ganun eh. Kailangan maintindihan natin yan para alam natin kung paano tayo magre-respond. Lalong-lalo na sa mga pasyente nating may diabetes. Very importantly, glycemia, control of blood sugar affects all this. Kaya importante pinag-uusapan natin yan. Ngayon, isa-isahin natin itong anatomical and chemical barriers, pero very briefly lang ha. Yung mucus, phlegma. Importante pala yan. Importante pala yan, no? Kasi in phlegm, no, pagka sinisikret yan, meron din yung immunoglobulins. Ang tawag dyan, immunoglobulin A. IgA ang nasa mucus. In fact, there are certain kinds of vaccines, no, na talagang sa mucus nila dinideliver inhalational, no, para mag-produce ng maraming IgA against these specific viruses. Saliva is also a chemical barrier. Mga bata tayo, pinaglalaroan natin lawan, no? Pero it's a form of chemical barrier. Or pwedeng anatomical din, no? Pagka napunta sa laway yung virus at na-spit natin yan, no? Matatanggal din, may tataboy din yung virus. Stomach acid. Mahirap yata makalusot dyan ng kahit na ng virus. In fact, if you put a piece of metal sa stomach natin, susunugin yan ng muriatic acid dyan. That is highly acidic. Ganun katapang yung acid stomach. Sa mata, tears. Tears is a form of protection din. Pag pumatong dyan ang bacteria or virus at na-irritate yung mata natin, nag-lacrimate, yung dami ng tears, iniluluha niya, tinatapon niya yung mga parasites. Kaya it is again a form of defense. Yung skin natin is topped by a layer of dead cells. Walang virus na makakadaan sa dead cells. Kailangan ng virus alive cells that are living, no? Scabs. Yung scabs, yan yung natutuyo pagka nagkakaroon ng break sa skin. Skin is proteinaceous, but then again, it does not allow pathogens, parasites to get into the wound. It's a form of protection. Kahit nasugat tayo, may protection pa rin tayo. And then there are the proteins na nire-release ng mga sub-epithelial cells, no, in response to the entry of foreign matter. Pag may nakapasok na mikrobyo under the skin, they release epithelial defensins. Mga proteins yan na nagpapadala ng signal doon sa nakatagong cells. Tagong cells, no? Yan yung mga nagre-respond sa infection, mga T cells, mga plasma cells, then they can respond faster doon sa entry ng microbes. Then, at the same time, may nag-aabang sa ilalim ng tissue natin. May nag-aabang dyan ng mga phagocytic cells. And the phagocytic cells themselves also contain defensins. Once they sense that there is foreign matter, non-specific, hindi specific, gagawa siya ng defensins, phagocytic defensins, para ma-recruit yung mga T cells, yung mga killer cells, natural killer cells, na nasa other parts of the body. But on top of that, there are certain microbes, no, na friendly, na hindi pathogenic, na part of other microbiome, no, that may also produce defensins. No? May mga bacteria na normal sa balat natin, sa ibang parte ng katawan natin, kapag nakakita ng offending agent like a virus, they will make microbial defensins, and this can be sent across. They can be sent to the T cells and B lymphocytes to make an appropriate response. Pero non-specific pa rin yan. Non-specific pa rin yan. So these are anatomical and chemical barriers. Pag-usapan natin yung intrinsic barriers kasi pag nakalampas dun sa first barrier yung mga virus, nandyan yung intrinsic barriers. Yung interferons, no? Interferons is an overlap. Maraming klaseng interferons. There are at least 3 kinds. Pero yung interferon alpha, it's always there, nasa cells yan. Pag may nakapasok na cell sa virus, magre-release yung cell ng interferon alpha to warn adjacent cells to be ready para pagka dumating sa kanila yung invading organism or virus, they are ready to react. So that's interferon. Yung ibang interferons, there are other pathways and they interlock with the other defenses. Intersect din yan doon sa iba pang defenses. Hindi lang sa intrinsic, pati sa innate, nagpa-participate din ng interferons. Pero yung gamot na binibigay, di ba? They tried interferons sa COVID-19 Pero walang nagagawa kasi it's non-specific At saka you have to give it very early kung sakali. Pagka may infection na halos wala na siya magawa. This is something that you should not memorize. No? Gusto ko lang i-impress sa kayo, sa ating lahat, no? Na may iba pang mechanisms ng cellular defenses against viruses. This is a slide from a virology lecturer, si Vincent Racaniello sa Columbia University, that I really do not understand. Yung siya lang nakaka-explain niya, no? Ang naintindihan ko lang dyan, no? Na pag ang virus lumabas sa cell, papasok yan sa next cell, no? At mag-divide na naman yung kanyang nuclear material. Pero in the presence of apolipoprotein B-mRNA editing catalytic polypeptide, yung ApoBec na yan, no? Sasama siya dun sa viral particle. At pag sumama siya sa viral particle at nag-invade ng bagong cell, it will cause a mutation that will cause the RNAs to be chopped into smaller pieces and they can be degraded. So, may cellular and the biologic defenses din pala na binibigay sa atin si Lord. That is what struck me. Ako, yung mga mechanism yan, ang hirap ng tandaan, no? But there is something else na tinuturo si Professor Racaniello sa lecture niya. Sa cellular real pa rin, ano? May isa pang defense mechanism na tinatawag na epigenetic silencing. Yung mga cells pa natin are making a lot of histones, mga protein substances na yan. Kapag ka nakakita sila ng abnormal RNA or DNA or abnormal nucleic material doon sa cytoplasm, didikit sila doon. At hindi nila i-allow na mag-replicate or mag-translate yung RNA. And the RNA will remain there silence. Kaya ang tawag ay epigenetic silencing. Again, it's a cellular defense mechanism. Bigay pa rin ni Lord yan. It is there. No? Yung autophagy, tsaka apoptosis, they are also cellular mechanisms. Ang cells natin, no, pagka nakita niya na natatalo na siya, namamatay siya because of an infection, it will die by itself. It will set off a cascade of reactions that will cause bleeding and cell death. Ang tawag doon, apoptosis. Pag namatay yung cells na yan, all the nutrients, no, na mapupunta sa maliliit na pieces, tinatawag na apoptotic bodies, they can be reused again to make new healthy cells. So that is the function of apoptosis. Normal yan. And many cells, no, lalo na yung mga phagocytic cells, yung mga killer cells, kukunin nila yung apoptotic bodies na yan. I-engulf nila in a process called phagocytosis. So they usually come together, apoptosis and phagocytosis. And what is good dito, may overlap na naman ito no? With the specialized immune system, immune compartment of the immune system. Kasi pagka na-engulf niya yung mga abnormal antigens, RNAs, DNAs, pinipresent niya yan doon sa mga B cells and T cells to be remembered. So, again, that is a system that is given to us para hindi tayo sitting duck na lang against any kind of virus. Another intrinsic barriers would be the microRNAs. Yung mga microRNAs, pinagtatalunan pa niyan nila kung present yan sa mammalian. Pero meron sasabi, possible daw Ang sinasabi nitong actually theory, pero na-prove nila sa ibang cells to There are dicer proteins in the cytoplasm. So that when a virus enters and senses a double-stranded RNA, double-stranded RNA does not happen in our species. Ang double-stranded sa atin, DNA. Pero pag nakakita tong dicer molecule na yan ng double-stranded RNA, sinachop niya into smaller RNAs, which are called siRNA or small interfering RNAs. So that when a new virus enters, those small interfering RNAs, na tawag, they interfere with replication of the RNA of the virus. Kaya hindi natutuloy yung replication of virus. And this is again a defense mechanism provided by the cell. And that is the same with the CRISPRs. Yung CRISPRs usually sa bacteria yan, pero lahat naman tayo, normal naman yung bacteria natin, Yung CRISPRs, yung clustered regularly interspaced short palindromic repeats, mga paulit-ulit yan, na segments of RNA that interferes with the replication of the viral nucleic material. So we have a lot of defenses. But even though we have lots of defenses, through time, yung virus dahil sa mutation, nakakahanap pa rin siya ng paraan para maka-beat around those defenses. But do not forget, hindi tayo pinabayaan ng Lord. Dami nating defenses. Then, we have the innate immunity. Innate. Ito hindi laging nandyan. It has to be activated. Pero, this immunity is non-specific. Kahit anong virus na pumasok, it will kill that virus. Innate immunity. but it entails a little immune response. Nandyan yung mga natural killer cells, no? Actually, yung mga phagocytes na-expose sa antigen o nakakuha ng antigen, ipipresent niya yan sa T helper cells. Yung T helper cells pupunta ngayon sa sa mga nodes, lymph nodes. Nandun naghihintay yung mga natural killer cells. Dadalhin niya dun yung message, yung antigen. Kaya mapupuntahan niya ngayon yung mga infected cells na merong ganong klaseng antigen, and the natural killer cells will usually engulf the infected cell. Mamamatay yung infected cell, but it will become substrate for the production of newer, healthier cells. So, that is innate immunity. Ang ganda ng process na binigay sa atin, Lord. Yung complement, no, is another one. No? Ako hindi natin pag-usapan yan. Isang buong lecture yan. Isang oras yan. But the complement is a cascade of reactions. Maraming proteins yan, no, that will stimulate the entry of more phagocytic cells, no? More phagocytic cells from the nodes and from the other parts of the body. There are different pathways wherein the cascade goes through. We are not going through them one by one, no? Kasi ako, kailangan ko pag-aralin uli yan, no? Pero kita nyo, no? Hindi tayo pinabayaan ni Lord. Binigyan niya tayo ng maraming defense mechanisms. How about yung mga cells na nagpe-present ng iba't ibang antigens, no? Meron tayong mga cells sa ilalim sa subcutaneous area. Ang tawag doon dendritic cells. DC yan, dendritic cells. Marami siyang antigens around Namamana natin yun yung mga antigens na yan Pero it's still not specific kasi namana natin. No? But then again, it can be activated, no, by the presence of virus. It talks to helper cells. The helper cells, pagkatapos ina-activate niya yung mga polynuclear cells para bumalik at mag-provide ng respac para patayin yung virus. And not only that, marami pang antigen-producing cells, yung mga plasma cells nasa sa ilalim ng epithelium ng subcutaneous area. They also participate in antigen-presenting cells. Then we have neutrophils. Yung neutrophils, alam na natin yan kasi pag nakapasok siya sa infection site, nagiging natural killer cells ang mga neutrophils. And then, of course, we should not forget the participation of the cytokines. It's part of the innate defense mechanism. Saan ba nagagaling yung cytokines? Ang daming gumagawa ng cytokines. Yung mga modulators of inflammation and inflammatory response. Those are the cytokines. I'm not going through them one by one, no? Pero we have to understand at this point, no, that a gamut of cells participate, no? Macrophage, lymphocyte, mast cell, endothelial fibroblast. Hindi tayo pinabayaan ni Lord. Maraming gumagawa ng cytokines. In fact, no, doon sa severe COVID niya, nakakalungkot naman, nagkaroon ng abnormal cytokine response. Sumobra yung cytokine response. Ang tinatawag na cytokine storm. And there are cases na wala na yung virus. Nandun pa rin yung virus, hindi mawawala ng 100% yan. Hindi na siya nasa-set off as infective. Non-infective na yung mga individuals. Pero nagsa-cytokine storm pa rin sila. And those are things that needs explanation pa. Siguro after another quarter or 6 months, na-explain nila lahat yan in more details. But nevertheless, do not forget, dami nating defense mechanisms na binigay ni Lord, hindi tayo sitting duck. Finally, yung adaptive immunity. And I told you earlier that I will not discuss this in detail. Ang importante lang, no? You know that there is beta lymphocytes, T lymphocytes na re-recognize into memory yung specific invading particles. Kung yan ay virus at nakaabot yan sa lymphocytes na memorize nila. Sa T lymphocytes nga, mayroong special T cells na tinatawag na memory T cells. Once they have the memory, every time there is another infection of the same kind, memorize na niya yun. Papadala na niya sa killer cells. Stimulate na agad yung killer cells para patayin yung invading particle. No? Before I close this, no, I should not forget to remind you yung difference ng specific at saka yung non-specific immunity. No? Yung specific immunity, kailangan talaga ng antigen to stimulate that response. Kaya yung mga bata na hindi pa na malakas pa yung kanilang mga first three defenses, yung intrinsic, yung innate, at saka yung chemical anatomic barriers, lakas nilang lumaban sa lahat ng invading organisms, invading viruses. But as we grow older, kailangan natin talaga ng ma-develop an innate immunity. Napaka-importante talaga ng vaccines. Yung nga lang, pag may bago tuloy, no? May bagong invader like SARS-CoV-2, then it will tell us another story. It is a completely new story. Bago sa atin yan. Yan, sa bagong testament naman, kinonfirm lang ng ating Bible na the Lord is faithful, He will strengthen you and protect you. Hindi tayo pinababayaan ni Lord. No? Kaya dito sa lecture na to, no, kung sasabihin natin, no, na all the while, akala natin, no, nilalayo tayo ni Lord dahil dito sa sakit na to, hindi pala. All the way, kasama natin siya. Kasama natin siya, tinutulungan siya tayo, pero no, kailangan tulungan din natin ang sarili natin. E paano natin tutulungan sarili natin? Gamitin natin ang science. Sa science natin nalaman na nandito si Lord. Kaya sa science din natin malalaman kung paano natin matutulungan yung sarili natin. Wear mask. Mask tayo lahat. Maglinis tayo ng kamay madalas. Saka yung social distancing. Yun ang tinuturo ng science. Si Father, nakalimutan. Hinihintay ko sabihin niya, huwag lang maghugas ng kamay. Buti nila, hindi niya sinabi yun. Ang sinabi lang niya, pwede na daw hindi mag-social distancing, pwede na daw hindi mag-mask. Teka muna, hintayin natin na sumagot si Lord sa atin through science din naman. Hindi naman tayo binibili ni Lord. Kaya next time, pag nagkaroon ulit tayo ng time, ang magandang pag-usapan yung tinatawag na adaptive immunity. And that will include yung ano ba talaga yung bakuna? What is vaccines? Siguro in a manner na maintindihan natin lahat, na ma-explain natin sa pasyente. Usapan natin yan next time. So thank you very much for listening.
Hey, thank you.
Hello. Yes.
Dr. Elwin Fernando. So before we proceed with our second speaker, we will just show you some MTV from the ISD Convention 2020. Let's roll. Okay, thank you.
Okay. So, we encourage you to please set in your questions kahit po yung pertaining to topics that have been presented before on diagnostics and coagulation in diabetes and of last week, management of diabetes among patients with COVID. Our speakers are all here. Si Kuya po kasi is not available tonight. So, we just go clinical tonight. Pag-usapan natin yung lahat about COVID from diagnostics to management of diabetes. And then tonight, we have another very interesting topic, which is the management of COVID in a diabetic patient. Last week was management of diabetes in a patient with COVID. Good friend of ours, she is a member of the board of trustees of Diabetes Philippines. She is currently the president of the Philippine Hospital Association in Bulacan. She had her masteral in internal medicine, major in diabetology at the UERMISD. She is currently the medical director of Our Lady of Mercy Hospital. She is the president of the board of Our Lady of Mercy Hospital. Let us all welcome our good friend, Dr. Maria Marcy Cruz. Good evening, Mars.
Good evening. Thank you, Pat, for that kind introduction. So, let me share my slides to you. Okay na ba?
While waiting up, please put your name in our chat box for attendance.
Okay. So, can I start now? Hello?
Okay na po.
Go ahead, Mars.
Okay na. Okay
po.
na. Updates on the management of COVID-19. Oops. Okay. So, I'll go with this outline, the classification of patients with probable and confirmed COVID-19, the algorithm for COVID-19 referral and triage, the supportive therapy and monitoring, management of COVID-19, acute respiratory distress syndrome, severe sepsis and septic shock, then the investigational therapies. So, as of September 30, we have 33 million worldwide COVID-19 cases, and we have a total death rate of about 1 million. In the Philippines, last September 30, we have 300 plus, and the death is about 5,000 plus. So, nandun pa rin tayo sa within the limit na mababa pa rin yung ating death, which is about 2 to 3%. So probably we could congratulate the doctors that we have na less pa rin ang death in spite of a high COVID-19 cases. So now we go now to the classification of patients with probable confirmed COVID-19. They're classified to mild, moderate, severe, and critical. When you say it's mild, they have the fever, cough, fatigue, anorexia, myalgia, and the non-specific symptoms. Pero yung laging yung nadidinig, the nausea and walang sense of taste, But they have no signs of pneumonia or hypoxemia. Usually, they're managed in a community quarantine facilities. They're isolated for 14 days. However, patients who have mild symptoms pero diabetic, hypertensive, they are on immunocompromised because they are undergoing chemotherapy, they are usually admitted in a primary or secondary hospital because most of these patients will will progress into moderate or severe. They might. Then, with mild cases, we just give symptomatic treatment and supportive care. Empiric antibiotic may not be needed this time. How about the moderate? Now, the patient the signs of dyspnea or difficulty of breathing with a respiratory rate of 21 to 80 per minute with an SpO2 of more than 92 on room air. But chest X-ray, now we see a non-severe pneumonia. This is usually admitted on a primary or a secondary hospital for further observation. The severe type, we have now a more dyspneic patient with a 30 beats per minute of respiratory rate and a SpO2 of less than 92 on room air. We could see a very severe chest X-ray. Halos namumuti yung kanilang lungs. So, usually these occur after a week of being admitted as moderate in a hospital setting, or the patient may present on the first day in the hospital. No, there is as days goes by, there is progression of the infiltrates on chest X-ray and also in chest CT scan. The progression usually cannot be explained by the cardiac failure or fluid overload. So they usually, once this patient go into sepsis and septic shock, this we call patients that are critical. So the algorithm of COVID-19 referrals and triage, this is the overall picture of the triage of how do we refer these patients. So I go them one by one. So patients with mild cases, usually they are isolated in community care. As I mentioned a while ago, those patients with mild but with comorbid and elderly, they will be hospitalized in a primary or secondary hospital. However, if this progress or upon assessment, the patient is dyspneic, we could admit the patient in a level 2 or a level 3 hospital. Once they are admitted and progresses, ito na, mapupunta na sila sa ICU. They'll be, kung kailangan silang i-monitor and be intubated. And in this setting, we have to refer to an intensivist, pulmonary, rheumatologist, if available. Okay? So, but patient, yung mga nag-improve, may nag-i-improve, ano? Once they improve, they may go back to the community quarantine once they are discharged from the hospital for another 14 days of quarantine. So, this is an algorithm in the respiratory management of critically ill patient, which was released October 4 by the Philippine College of Chest Physicians. So, detailed yung kanilang ginawa, especially with the mechanical ventilators. But ito, madadaanan ko as we go along. Okay? So, the next, we have the supportive therapy and monitoring of COVID patient with pneumonia. So, supplemental oxygen is the first response. Pwede tayong mag-nasal, pwede tayong mag-high flow nasal, or non-invasive passive pressure ventilation. Basta ang tina-target natin an SpO2 of more than 92%. Okay? So, ito dapat nating matutunan. We have to compute for the ROX index. The ROX index is the SpO2 over FiO2 divided by the RR. So, if the ROX index is more than 4.88, we can maintain our O2 support. However, we have to reevaluate or recompute our ROX index 2 hours. If it is less than 2.8, we have to perform intubation. If we reevaluate again on the 6 hour, if it is less than 3.47, again, we have to intubate the patient. And again, we have to reevaluate the patient after 12 hours. If the ROX index is less than 3.85, then we have to intubate our patient. Then, we must not be too aggressive in resuscitating our patient kasi baka mag-worsen pa yung patient. We may push them into congestion. Kaya dapat keep the lungs dry. There must be a conservative fluid management. Then, an appropriate empiric antibiotic within 1 hour of identification of sepsis. Yung recommendation, yung pa rin sinusunod natin yung guidelines ng CPG. For low risk, community-acquired infection, without comorbid, we just use amoxicillin or azithromycin. But for patients with comorbid illness, we know beta-lactam inhibitor combination, or a second-gen oral cephalosporin plus an extended macrolides. But for moderate risk, ito na yung mga pasyente nating diabetic, lagi tayong ito yung mga antibiotics nating gagamitin. We have the beta-lactam and beta-lactam inhibitor plus extended macrolides or respiratory quinolones. For high-risk patient, so ito na yon, we can use no risk for Pseudomonas or high risk for Pseudomonas. So the difference is that in a patient who are at risk for Pseudomonas, we added carbapenems, extended macrolides, or aminoglycosides. But if we expect an MRSA pneumonia, we added vancomycin, linoleucid, and clindamycin. So, pareho lang din. So, we also give corticosteroids. Usually, we give dexamethasone 6 milligrams per day for 10 days. I will expound on this based on the recovery trial. So, we now have the management of COVID-19 with acute respiratory distress syndrome. So, usually there is a worsening manifestation on the part of the patient. And the chest, we have a bilateral opacities. And the edema, the respiratory failure not fully explained by the cardiac failure or fluid overload. So they could be classified, the ARDS can be classified based on the PF ratio. Mild for those who have 200 to less than 300, moderate for PF ratio of 100 to less than 200, and severe for less than or equal to 100. So naturally, we have to place the patient on ICU, and we have to recognize the severe hypoxemic respiratory patient of respiratory failure of this patient. And we have to refer this to appropriate specialists. Once yung mga pasyente mag-i-intubate, it must be done by a trained anesthesiologist, kasi dapat naka-PPE na tayo because we know that intubation can induce airborne infection. And ito, be mindful na hindi tayo gumagamit ng bag mask ventilation or mass ambubagging as pre-oxygenation. Instead, we just place the patient on 6-liter oxygen via nasal cannula. So talagang itatago na natin yung mga ambubag natin. Okay? Then, the lung is, so unti-unti silang naglalagay ng PEEP sa mga pasyente. Remember, COVID patient who are intubated are always sedated. Na pinapatulog sila. Ginigising lang sila kung okay na silang iwin sa respirator. Pag nakita ng mga attending physician na yung lungs ay gumaganda, this is the time na unti-unti nilang gigisingin para makipag-cooperate siya sa weaning ng ventilator. And nakikita natin, if the patient remains hypoxemic in spite of the ventilator, we put the patient in a prone position for no less than 12 hours with the goal of lung recruitment. So, but if this fail, nagpe-fail pa rin, eto na, gagamit na tayo ng extracorporeal life support. Eto. Kasi yung lungs hindi na kayang mag-perform. So we use other ways na nilalaktawan natin siya. So we use the ECMO na tinatawag natin. Okay? Then again, another reminder, nebulization is not recommended. Instead, use metered inhalers if necessary. Another management for ARDS is the use of anticoagulant. We know that if the D-dimer level is more than 1,000, we could use heparin and low molecular weight heparin. Diniscuss na ito ni Danny kung bakit ganito. Kailangan nating gumamit. So, next is the severe sepsis or septic shock. So, usually, ganyan pa rin yan. Remember that all patients, once admitted, we have to do a blood culture. And you have to give the appropriate antibiotic within an hour. So, kung pagdating ng pasyente, iniisip mo septic shock kaagad, siguro maiisip natin community-acquired infection. However, kung galing na sa iba, referred lang sa level 3 or level 2, nag-iisip tayo ng hospital-acquired infection. Or if the patient is matagal na sa ospital, nag-iisip na rin tayo ng hospital-acquired infection. So again, yung fluids natin, we have to resuscitate them with our fluids. Natural, bibigyan natin ng vasopressor, bumabaksak na ang kanilang BP, with the vasopressin, with norepinephrine, dopamine, and dobutamine, with the target blood pressure of mean arterial pressure of more than or equal to 65 millimeters mercury. We also considered intravenous corticosteroids, and tayo din, nagwa-warn tayo sa ating pasyente. We have to discuss the end-of-life issue once nakita nating napaka-toxic ng pasyente. So, that is the management of pareho din sa mga pasyente nating nag-pneumonia or severe pneumonia. Parehong-pareho din. So, we now talk on the investigational therapies for the treatment of COVID pneumonia. These are divided into two: drugs with anti-SARS-CoV-2 activity and the immunomodulating agents. So, these are the drugs, as you see in your monitor. Before I go through with them, I have to review the life cycle of SARS-CoV-2. We know that the first step is for the virus to come in through binding with the ACE receptor located in the membrane of the cell through membrane fusion or endocytosis. Once they are in the cell or in the cytoplasm, they release the viral genome. And again, through the viral polymerase protein, they undergo RNA replication. Once a lot of replication is done, ayan, nag-a-align na sila. The translation of viral structure proteins are aligned in the S, M, and E of the endoplasmic reticulum. And the next stage is to be combined with a nucleocapsid, thus forming a matured virion, and they exit the cell as a new virus. So kaya ko mini-mention yan kasi importante yung life cycle. Kasi dito makikita natin kung saan nag-a-act ang different drugs or the antiviral as well as the immunomodulator. This is just an illustration of the different drugs or antiviral drugs kung saan sila nag-a-act on the different cycle of SARS-CoV-2. So, the first investigational drug that we talk to is the remdesivir. So, the mechanism of action of remdesivir, it is an RNA-dependent RNA polymerase inhibitors. It inhibits SARS-CoV-2 replication. The dose regimen is 200 milligrams IV loading dose on day 1, followed by 100 milligrams once a day for 5 to 10 days. So, this is just an schematic diagram. So, this is where the remdesivir do work at they stop the RNA replication. These are the evidences wherein remdesivir is useful in the treatment of COVID-19. This is the final result. This is the final report on remdesivir, which was released October 8th. No? So they have found out, they showed that remdesivir was superior to placebo in shortening the time to recovery in adults who were hospitalized with COVID-19 and had evidence of lower respiratory tract infection. So the result, those who received remdesivir had median recovery time of 10 days as compared with 15 days among those who received placebo. The patients who received remdesivir were found to be more likely than to those who received placebo to clinical improvement at day 15. The Kaplan-Meier estimates of mortality were 6.5% with remdesivir and 11.9% with placebo by day 15. By day 19, 11.4% with remdesivir and 15.2% with placebo. So this is just a graph showing to you the proportion of recovery with remdesivir overall and those patients receiving oxygen and ventilator and those who are not. We could see that remdesivir had more recovery for patients who receives oxygen as well as high flow oxygen and non-invasive mechanical ventilator than that of patients who are not receiving oxygen. Pag tinignan niyo yung graph, by day 5 and 6, may improvement. However, may mga pasyenteng lumulubha pa rin, like those on the graph in letter D. Now, gumanda sila, pero pumapangit later. Pero may effect pa rin yung remdesivir. Nakita nyo yung separation ng line. No? Pero at the end, yun pa rin, may oras na pumapangit pa rin yung pasyente. So, for those patients who are receiving ECMO or nakita nyo halos pareho lang yung effect. No? Halos yung recovery is just the same. Okay? So this is just an outline and the outcomes, the overall outcomes comparing remdesivir with that of placebo. So makikita nyo mas madami-daming recovery with that of, this is the 7 meta-analysis that has been discussed. So this is just time to recovery that favors remdesivir. So nakita nyo sa lahat ng mga characteristic nandoon, mas greater yung remdesivir. Then, merong secondary outcome when it comes to median time to clinical improvement, 7 days to the remdesivir as compared to 9 with placebo. The median duration of initial hospitalization is 12 as compared to 17. And the oxygen, no, hindi na sila gumagamit ng oxygen, mas mabilis sa remdesivir. In 13 days, hindi na nila kailangan ng oxygenation as compared to 21 sa placebo. And also, doon sa nag-progress, mas kakaunti yung nagpo-progress into ECMO and high flow oxygen as compared with that of placebo. So with that, we could say that remdesivir now has a moderate evidence for the use in COVID-19 pneumonias. So there is a study wherein is it a 10-day course of remdesivir and a 5-day course remdesivir. Actually, in the report, they have used a 10-day course. However, this is just an initial report last July, wherein the 5 days and the 10 days are almost the same. So we could see in this chart, wherein the 10 days and the 5 days remdesivir is almost the result was almost the same in the different study. So remdesivir, now the recommendation, there is sufficient evidence to recommend the routine use of remdesivir among hospitalized patients with mild to moderate COVID disease. There is a strong recommendation with median quality of evidence. Now we go to chloroquine and hydroxychloroquine. They block the entry of the virus sa ACE receptor. So they have also a proteolytic processing and endosomal acidification. They have immunomodulator effect through attenuation of cytokine production and inhibition of autophagy and lysosomal activity in host cells. So dito nag-a-act ang chloroquine and hydroxychloroquine. So upon entry sa ACE receptor. Okay? So these are the evidences that shows that hydroxychloroquine and chloroquine did not find an effect or negative conversion of SARS-CoV-2 by 28 days by Tang et al. In 2019, Rosenberg in 2020. This is a retrospective study that there is no effect of HCQ on the risk of intubation or mortality. And a lot of adverse effects are common. This, alam niyo na to, yung prolonged QT that causes arrhythmia. Then the preliminary reports of the recovery trials that was released June 5, they have concluded that the hydroxychloroquine does not reduce the risk of death among hospitalized patients with COVID-19. And there is no significant difference on the primary endpoint of 28 days mortality as compared with that of the control group. The preliminary analysis on the data from the WHO Solidarity trial also showed no significant difference on inpatient mortality among patients randomized to hydroxychloroquine compared with the standard of care. So finally, so the recommendation Even they are used in combination with macrolides and any antiviral agent, they are no longer recommended for hospital patients with probable or confirmed COVID-19 pneumonia. Go to the next drug, the lopinavir, ritonavir. This drug are used for HIV patients. Maganda sila because they are protease inhibitor administered in a fixed combination with ritonavir, which has a potent CYP3A4 inhibitor that increases the concentration of lopinavir. So dito naman nag-act ulit sa they inhibit the RNA replication. So trials, again, this is an open randomized open trial ng lopinavir and ritonavir in hospitalized adults with COVID-19. There was no benefit observed with lopinavir or ritonavir as compared with the standard of care. So with this, they are showing you through the graph that the time of clinical improvement in the intention to treat the population is not significant. As well as the conversion of a positive throat swab, there was no difference with that of the control group or the standard of care. So the recommendation, so they must not be used as monotherapy or in combination with hydroxychloroquine or immunomodulator or an antiviral agent. So, hindi na sila nire-recommend. So, we now go to favipiravir. It inhibits the polymerase and prevent replication of the viral genome. They prevent the entry and exit of the virus from cells. Dose regimen is 1,800 milligrams twice a day. That is the loading dose. Then give 800 milligrams twice a day for 13 days. Ang preparation nito ay 200 milligrams per tablet. So the patient will take a lot of tablet to get the loading dose as well as the continuation or the maintenance dose for 13 days. So, dito nag-a-act ang favipiravir. So, exit and entrance as well as the inhibition of the polymerase protein that will prevent RNA replication. So, what are the evidences? We have in Chen et al. In 2020, the rate of recovery did not differ significantly between that of favipiravir and the standard of care. However, in Kai et al. In 2020, there was an independently association of faster viral clearing and chest CT scan improvement. Then by James et al., by 2020, majority of patients with mild to moderate disease recovered from the illness. Whereas in those with severe disease, the results were not encouraging. Usually, favipiravir must be taken early in the disease to have a good recovery on COVID patients. So again, the recommendation, there is insufficient evidence to recommend routine use of favipiravir for the treatment of COVID-19 except in the context of clinical trial or for compassionate use. We go now for the immunomodulating agents. We have the corticosteroids. It inhibits multiple inflammatory cytokines, resulting in decreased edema, capillary leakage, and migration of inflammatory cells, thereby globally suppressing the inflammatory response. The steroid use is dexamethasone given 6 milligrams once a day for 10 days. So these are the evidences. The recovery collaborative group state that in patient hospitalized with COVID-19, the use of steroids resulted in lowering the 28-day mortality among those on ventilator machine and on oxygen, but not among those receiving no respiratory support. So this is the primary and secondary outcome of dexamethasone, showing to you a decreased mortality at 28 days as compared with that of the comparator group. As well as the death, there is less death with the use of dexamethasone than the comparator group. Okay, so the recovery trial state that there is a reduced death by 1/3 in patient receiving invasive mechanical ventilator, 1/5 in patient receiving oxygen without invasive ventilator, but did not reduce mortality in patient not receiving respiratory support. So this is the graph that shows you the mortality of that there is less mortality with patients who are on dexamethasone. As you could see in letter D, those who are not receiving oxygenation, walang masyadong naging malaking difference. So, ginagamit lang natin ng steroids kung hypoxemic ang pasyente natin. Once the patient is not hypoxemic, we are not to use dexamethasone. So, this is just to show you that dexamethasone is better. Another graph showing you the effects on mortality. So the overall recommendation we could use dexamethasone as an adjunct therapy in patients with COVID-19 requiring oxygen support. Inhaled steroids are not recommended for the treatment of COVID-19 pending the results of ongoing studies. Oral inhaled IV steroids are not recommended for prophylaxis or prevention of COVID-19. Then we go to tocilizumab. This is a recombinant humanized anti-human interleukin-6 receptor monoclonal antibody that specifically binds S and M interleukin-6R and inhibit the signal transduction. So as you could see in the illustration that this tocilizumab can prevent further cytokine storm. So the dosage is usually 4 to 8 milligrams per kilogram single dose with recommended dose of 400 milligrams IV diluted in 0.9 normal saline to 100 cc given as a 2-hour infusion. And some have an extra dose after 12 hours. They repeated the same dose. So this is a meta-analysis on the study of tocilizumab for severe COVID-19. So these are the 7 study, no, na ongoing. So the result, the risk of mortality between tocilizumab and compared to the comparator favors tocilizumab. However, in patient na nasa intensive care unit at nag-re-respirator sila, the same yung result between tocilizumab and the comparator group. Walang difference. So, ito na yung nagme-mechanical ventilator. So, again, the recommendation, there is insufficient evidence to recommend the routine use of tocilizumab or other interleukin inhibitor to severe COVID-19 patient suspected to be in cytokine storm, except in the context of clinical trial or for compassionate use. Then we have the convalescent plasma. It is an antibody transfer to provide a passive immunity, no? So other plasma component may enhance the antiviral and anti-inflammatory properties of convalescent plasma. Here we have the schematic diagram on how it works, ano? So kinukuha 'yon sa mga naka-recover na COVID patient. Doon sa plasma, nagko-contain ng antibodies, ng anti-inflammatory cytokines, together with the clotting and anti-clotting factors, and albumin with the protein C and S. They have also the immunoglobulin and the IgG will attach to the spike of the virus. Kaya nagdi-decrease yung virus, antiviral effect. They neutralize the cytokines, complement, and autoantibodies. These are their modulatory effect. So, this is a paper which published in JAMA in 2020, wherein showing to you the evidence that convalescent plasma can be used. In this, we could see that the cumulative improvement, we could see that meron, no, doon sa pasyente overall, but especially in severe cases, but not in life-threatening diseases. So therefore, it is insufficient again, the evidence to support the use of convalescent plasma. But it may be considered for compassionate use and for eligible patients with moderate to severe COVID-19 in institution where there is an ongoing clinical trial and duly approved by the appropriate corresponding institutional regulatory board. Then we have the interferons na diniscuss ni Kuya, na they are the referred to the innate cytokines that make host cell refractory to virus replication. This is a small preprint randomized open label clinical trial showing you 100 cases of COVID-19 patient in Iran. But this does not show a difference with that. There's no difference in the time to clinical improvement with interferon group and the standard group. However, early administration significantly reduced mortality. Ito sinabi ni Kuya, if it is given very early. So another study wherein interferon was given with other antiviral agent. Ito tinignan nila yung conversion ng swab, and there was no difference. But the initial reports of the triple therapy, triple to, no? Triple yung ginawa. There was a significant reduction of the duration of viral shedding. So, interferon ulit, insufficient evidence with the routine use of interferon. So, hemiperfusion, another way of eliminating the cytokines. This is a form of dialysis using a dialyzer just to catch or capture the cytokines. It prevents the cytokines from lying on the walls of the alveoli and pulmonary arteries, and it prevents the incidence of ARDS and its progression. So makikita yung improvement dito kasi yung FiO2 ng pasyente after dialyzing the patient, nag-i-increase yung FiO2 nila. However, yung pasyente na filter din or naaalis din natin yung antibiotic, yung other substances na mga tumutulong sa atin para matulungan natin yung pag-kill or our natural immune systems. Nagkakaroon din ng problema. So, ang complication nito are secondary infection or more severe form yung iba, no? So, another way of hemoperfusion, pagka meron na tayong hindi na okay ang lungs as a source of, it could not perform as an exchange of oxygen. Ito na yung ECMO, the ECMO, wherein ginagamit natin to support or para ma-survive yung other important organs while waiting for the lungs to recover. So, sinusupport natin yung heart, the liver, and the kidney while waiting for the improvement. Or this is another paper wherein shows the evidence of extracorporeal blood purification in patients with COVID-19. Here is the graph showing you that the first few hemoperfusion, the first few days, usually sabi sa paper na ito, yung tatlong first hemoperfusion, very successful kasi nag-increase ng oxygenation from 89%, nag-increase ang oxygenation by 92%. However, as days goes by na ginagawa ito, parang hindi rin nag-improve. No? Bumagsak din yung oxygenation. So, again, ayan na naman, ang recommendation, insufficient evidence to support the routine use of hemiperfusion as adjunctive management of COVID-19 patients suspected to have cytokine storm except for compassionate use. We have the adjunct therapies. We have the vitamin C and zinc, melatonin, and virgin coconut oil. In-include ko na rin yung melatonin tsaka virgin coconut oil kasi last time, merong nagtanong tungkol dito. So we know that the vitamin C is a soluble vitamin with antioxidant properties and thought to attenuate organ-induced injury. And zinc is an essential mineral used to boost the immune system. At ang zinc then, together with hydroxychloroquine, sila yung nag-acidify ng cytoplasm, which becomes hindi na environment friendly para sa COVID pag nag-acidify ang ating cytoplasm. So evidence, there is again insufficient evidence with the use of vitamin C and zinc as adjunctive treatment for COVID-19. So, the melatonin, the mechanism of action, they are anti-inflammatory and antioxidant molecule. They reduces vessel permeability. Pero ito ginagamit for anxiety, sedation use, and improved sleeping quality. Pero this is a paper that studied melatonin. So ito yung schematic diagram showing to you how melatonin acts as an anti-inflammatory agent, thus inducing immune response on the part of the patient. So there is no significant data showing that melatonin limits virus-related diseases and would also likely be beneficial for COVID-19 patients. Additional experiment and clinical studies are required to confirm this speculation. The virgin coconut oil, our very own. So in vitro studies show that the lauric acid and its derivative has an inhibitory activities against viruses similar to coronavirus. In animal study, demonstrated an antiviral activity on the monolaurin. In vitro animal study demonstrated an anti-inflammatory properties of virgin coconut oil. There is currently one ongoing clinical trial in the PGH evaluating the use of virgin coconut oil as an adjunct therapy for COVID-19. They uses 15 ml of, they give patient 15 ml of virgin coconut oil 3 times a day. To date, there is no guidelines that mention virgin coconut oil as an option for adjunct therapy. So ending, so the clinical course of COVID patient, either they are discharged or they may succumb to death because of sepsis, ARDS, or acute cardiac injury, acute kidney injury, or a severe infection or secondary infection. So I would like to end as saying, the COVID-19 pandemic will pass, but the challenge to nurture our health is meaningful and feasible ways, and to avoid potential collateral effects will remain. Thank you. Haba.
Thank you. Thank you so much, Dr. Marcy Cruz.
Picture, kindly.
Am I on?
Yes.
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 Okay. Maraming salamat ulit, Dr. Marcy. I have, you walked us through the management of COVID. You presented all the drugs and other procedures that can be done to help our COVID patients. And for those of us who are seeing patients right now, myself included, surely learn a lot from you. And I am sure, just like me, they also have questions for you. I would like to ask the first question. No? Kasunod nito yung tanong na rin ni Jamie. Sa lahat ng gamot, Marcy, parang right now, ang nakikita natin parang promising that we can use sa nabanggit mo, no, among the antiviral would be the remdesivir and the favipiravir. Am I right?
Yes.
So, are these two drugs currently available? And among the two, the next question to that, how soon should we start it? And if we start it early, kasi dito minsan nag-argue kami ng mga pulmo. Kunyari ako ang attending, I want to start it because from experience, I have seen if we start it early, just like any antiviral drugs, the outcome is better. So, kasi minsan ang tagal ng swabbing, di ba? Tapos pag lumabas na negative,
2 days pa, 3 days.
mga 2 days, and then, in the guideline, parang dapat sa mga evidences, you have to start it early. Meron bang pwedeng mangyaring di maganda pag naumpisahan natin and then negative pala yung swab?
So, based on that, katulad din ng mga partners kong pulmo, pagka highly suspicious sila, pag una pa lang pagkita nila sa pasyente, very highly suspicious sila, they give remdesivir. Sabi nila, kahit ihinto naman after 3 days, wala namang effect, okay lang naman. Wala namang mangyayari sa pasyente. Only, syempre, mahal lang. Mahal lang yung gamot, pero walang mangyayari sa pasyente. Pero the advantage is that when you use remdesivir so early, you could see the difference or the improvement of the patient, especially on the clinical signs and symptoms of DOB. Usually, they improve from the 5th day to the 7th day. If they are on high flow oxygen of 100%, you could reduce the oxygen on the 4th day till the 7th day. And some of the patient, by experience, yung mga 7th day, parang gusto na nilang alisin yung high flow nasal oxygen nila for those who are in a form of moderate and severe. No? So, pwede silang gamitin immediately and there will be no effect except for, yun nga, masakit sa bulsa. They are now available in the Philippines. No? Dumadami na yung supplier natin, hindi lang kakaunti katulad before. Kaya dahil dumami yung supplier, hindi na sila ganong kamahal as before na narinig natin. Usually, the average, yung talagang puhunan ng mga pangkaraniwan is 6,600 to 7,000 na lang ngayon ang remdesivir. However, the favipiravir, available sila, no, sa Kasay. Katay ang nag-market dito. they are available in 200 milligrams per tablet. Expensive sila. They cost about 290 about 295 per tablet. I think that's the cost of yung kanilang tablet. Kaya lang nga napakadami mong ite-take. At saka ginagamit sila most of the pulmonary na ka-partner ko. Pag mild yung pasyente, gusto nila mawala kaagad yung fever at mag-convert kaagad yung pasyente into a negative swab in 7 or 10 days. So maganda sila sa mild to moderate. Pero for severe, hindi sila mas gusto nila yung nangangailangan ng auto inhalation, mas gusto nila yung IV na remdesivir.
Okay, so kasunod dun, Mars, so you give your remdesivir IV, nabanggit mo kanina, you give it 200 milligrams IV initially, then 100 milligrams daily. Ang tanong naman ni Dr. J.B. Agra, how long are you going to give it?
In the study, yung concluded study na sinabi ko sa inyo, no, the concluded study, they use it for 10 days.
Pero may study on 5 days.
Oo, the
Mars.
initial report, there was a study on 5 days na parang pareho lang yung effect ng 5 days sa 10 days, yung initial report. Kaya makikita mo those, may mga pulmo na gumagamit sa mild, pag nakita nilang mayaman yung pasyente, no? Kaagad, kahit mild yung symptoms, ginagamit na nila, but they just use it for 5 days. And what you could find out na yung pasyente, madaling nagne-negative yung swab. They do not wait for 14 days to be reswab. Nung una pa lang to, no? So, nire-reswab na nila yung pasyente on the 10th day. At makikita nyo, pangkaraniwang result, negative. Mas maraming nagne-negative.
Yeah, I agree with that, Mars. I also see that in my patients. You know, this forum is helping us a lot. Wala naman talagang masasabing expert sa COVID. We are all experiencing it all together. Yun lang maraming nakikita, mas natututo. Other than sabihin mong, syempre, they are pulmonologists and infectious disease, hindi din naman sila nagkaroon ng mga ganitong kaso. Parang sabay-sabay lang naman talaga tayong natututo. No? So, mabutit hindi tayo nahuhuli. Ang kay Dr. Nines Bautista naman ito, Mars, sinabi niya, point well taken, Nines, na remdesivir has side effects in the liver, so and we have to monitor the liver function and creatinine every 3 days.
Yes, yes.
Uh-oh.
And it cannot be used if the SGPT is 5 times elevated. So once 5 times elevated yung SGPT, we have to hindi sila pwedeng gamitan. At pagka ginagamit natin yung Decimir, naging more than 5 times, we have to stop the drug. Kasi magkakaroon ka ng side effects.
Hepatic failure naman na siya.
Hepatic failure.
Okay.
Kaya kailangan mong i-stop. Kaya minomonitor ang SGPT. So yan.
I want to go back, Mars, dun sa favipiravir. I have personally no experience about this. It's oral. It's very promising. Have you tried this? Have you heard experiences about this drug? How do you give it? How long do you ask your patient to take it? Please share with us.
Ang pangit dito yung ang dami-daming tablet. Kasi ang dami-dami mong tinitake na tablet. Kaya sana mag-produce ng mas malaking milligrams para hindi
Kala ko mas
masyadong
malaking tablet.
pagsama-samahin sana kasi biro mo 1,800 200 lang ang available. Actually sa experience ko ginagamit lang talaga nila sa mild cases. Halimbawa mild yung pasyente nagpunta sa ospital, may kaya yung pasyente, nakita lang mild pneumonia. Kasi ang kanilang sinasabi ng pulmo, yung daw fibrosis, hindi daw nagpa-fibrose yung lungs. pagka ginamitan ng Parivir. Kung makikita nyo sa mga pasyenteng dinidischarge, yung lungs nila hindi ganong ka-clear. Minsan nga, nagda-doubt kang i-discharge kasi hindi pa ganong ka-clear yung... Pero clinically, improve yung pasyente kahit anong gawin mong ABG. Normal na yung oxygenation. But the lungs, nakikita mo, and they have some, pagka nagda-doubt sila, nire-repeat nila yung CT scan, the chest CT scan, para lang makita talaga kung ano pa yan, kung meron pa yan. Pero pero nakikita nila it's a fibrosis. So, as they follow up the patient, may mga pasyente na nare-retain yung fibrosis at may mga pasyente unti-unting nawawala yung fibrosis. So, doon pumapasok yung kanilang paggamit ng Favipiravir. Kasi nakita nila, parang less yung nagpa-fibrosis pagka gumagamit sila ng Favipiravir sa mga mild cases. Kasi kahit mild yung pneumonia, nagpa-fibrosis din. Pinapauwi din nila yung pasyente na meron ding lesion. So, hindi ganun ka-clear yung x-ray pag nagpa-uwi sila. Magda-doubt ka pag nakikita mo, nag-x-ray, yun parang hindi ganun ka-clear. Tapos, yun nga yung sa experience din namin, I have to share it with you. Talagang mas maraming namamatay pag ini-intubate. Kaysa sa high flow nasal oxygenation. Mas maraming nabubuhay ang high flow kaysa pagka i-intubate na sila, parang nabibilis yung pasyente pag ini-intubate Kasi mukhang tama yung mga literature na lumilitaw na nakaka-damage yung kanilang pag-use ng vent, lalo na kaya very careful sila sa paglalagay ng tip sa mga pasyente.
Okay. So, may tanong pa si Dr. Nines. What phase can you give remdesivir and steroids? Na banggit mo na to kanina, Mars.
Oo nga. So,
na lang, clarify.
Oo. Initial phase pa lang, binibigay na talaga yung dexamethasone together with the remdesivir. Kaagad, initial phase pa lang. Those who are hypoxemic. But patients who are not hypoxemic, hindi talaga nila binibigyan ng steroids. Pero merong kaming ilan, may isang kaming pulmonologist na nagbigay. Again, nagtanong ako, bakit nagbibigay? Sa literature nyo, hindi dapat bigyan. Ito na naman, sabi daw niya, yung fibrosis na naman, mas less niyang nakikita pagka binibigyan ng dexamethasone. Kasi ito na yung base sa mga follow-up na mga pasyente nilang mild to moderate kasi pinaparepeat nila yung x-ray every time na nagpa-follow up sa kanila yung pasyente. Doon nila nakikita yung difference ng kanilang mga binibigay na management. Kaya parang yan, yung follow-up, hindi ko na nakikita yung x-ray pero sila na yung nakakakita ng x-ray.
So, sa steroids pa rin, Mars, no, the study you presented showed ang binigay nila was Dexa 6 milligrams once a day for 10 days. Doon sa present mo kanina, tama ba ako? Ang tanong ni Nines, which is better, methylprednisolone or dexamethasone? Meron ka bang na-encounter na
the reason why bakit nagbibigay ng long-acting? Actually, it's the long-acting, kaya pinili nila yon. Kasi para less exposure sa mga healthcare workers. We chooses steroids wherein long-acting siya. Maliless yung exposure ng mga healthcare workers. Kaya yun kaagad yung pinili nila than the short-acting that we have to give the patient every 6 hours. Yun lang. Pero dun sa sinabi ni Nice na methyl, wala akong na-encounter pa. Kasi kaagad ang lumitaw sa literature
dexamethasone.
Wala pa akong nabasa na gumamit ng methyl.
yung nabasa ko.
Meron kang
Meron ba?
nabasa na
Sige
methyl?
nga.
Hindi, pagka hindi daw available ang dexamethasone, pwede magbigay ng prednisone, kaya methylprednisolone, o
Oo,
kaya
kasi ang reason,
hydrocortisone.
yes, because the reason nga nila kung bakit DEXA, it's the less exposure of the healthcare worker sa exposure dun sa mga pasyente. Kasi para gawing once a day.
Eh baka si Nines ito, share niya ata yun.
Oh, nice. Ikaw nga, mag-share ka nga ng...
Asan ka, Nines, dito?
Oo, i-unmute mo kasi, Nines.
Nice. Wait lang.
Asan na si Nines?
Nice.
Yan, si Nice. Nice, unmute.
Nice,
Ayan.
hindi ka pa namin narinig.
Yeah.
Ayan.
Hello.
Isa din pong COVIDologist from Pampanga. Ito si Dr. Nines Bautista.
Can I share a
So,
slide?
isa siyang
Okay. Can I
expert.
share a
Yes,
slide?
yes.
Of course, yes, please, Nines.
Yeah. Kasi I just wanna share something to the group because I've been looking COVID patients for a lot of years. Okay? 4 months pala. So I sorry.
Sabi sa'yo,
So,
di ka
I
na
learned a lot.
diabetologist.
Kaya talaga,
Bidologist ka na
okay.
eh.
Go ahead, Nines.
Share. So you better read this journal, okay? Yan, you can see it now.
Yes.
Yeah, this is what you call the MAT protocol by Dr. Paul Marik. It's in the EVMS. It's East Virginia. So what they use in that, no, I've been using this before. I've been using DEXA because of the Philippine guideline. But now I'm using methylprednisolone. Tama naman si Mars, it's once a day. Methylpred is twice a day. Kasi nagtaka ako, one time my patient is on DEXA and then 7 day I stop it. And then the infectious disease put this patient on methyl. So I have to look for the answer for that. So this is the MAT protocol by Dr. Paul Marik. It is a combination of intravenous methylpred, high-dose intravenous ascorbic acid. No, this was discussed already. Thiamine, diniscuss na ni Danny. Low molecular heparin, statin, zinc, vitamin D, famotidine, melatonin, and magnesium. So halos na-discuss na natin yan. So ang sabi niya dito, no, ito yung kanilang course. Okay, this is their approach. Kaya nga sabi niya, this is a steroid responsive disease. However, clinical timing is very important. Kasi you have to look at the course, incubation period, symptomatic, early pulmonary phase, and late pulmonary phase. During the viral replication, that is the time that you can give your antiviral treatment. Sa kanila may ivermectin, it's an anti-antiprozoal, interferon, remdesivir, then vitamin C. Dun sa early phase, that is the time that you give your prednisolone. Sa kanila, it's not dexamethasone, but it's methylprednisolone. Okay? So, what is the reason behind that? So, if you look at this, no, you can download this. You will learn a lot. Okay? Matutuwa ka dito kasi I have seen a lot and it really works. Okay? So, kasi in their studies, the number needed to treat when you give methylprednisolone is less. Okay? Sa dexamethasone in the recovery trial, I think it's 28. Dito sa number needed to treat studies in Italy, methylpred. That is why I shifted now from dexa. Although,
Methylprednisolone.
Can you see it? Okay. Nakikita nyo?
Yes.
So, these are the published RCT cohort studies of corticosteroids therapy. Okay? You just read it kasi ito yung ginagamit ko. I'm not infectious disease. Pero nagtaka ako bakit yung infectious disease, pinalitan niya yung aking DEXA. Okay? So, the number needed to treat, meaning the lower the number needed to treat, the better. No? In a study in Italy, 2.7, 6.2, 7.8, 6.3, 10. Pero dun sa dexamethasone, it's a 28. Patients on oxygen, patients on MECVEN, 8.4. So, ito yung reason kaya I personally shifted sa methylpred because of the number needed to treat. At saka natuto ako dun sa aking sa pulmo. ay sa infectious. So nagtaka lang kasi ako bakit sa guideline, yun ang binibigay. Pero bakit iba yung binibigay niya? Okay? So you can unmute me now. That's just sharing.
Thank you, Nice.
Nine. Yung
Nines.
journal na sinasabi ni Nines, I already forwarded it to the PSD fellow PSD members. Kaya
Okay, thank you. Thank you, Jamie. Thank you, Nines. Yung sana sasabihin, huwag mo na kami ipa-search. Padala mo lang yan sa amin.
Oo.
Sinend ko na sa
Oo
inyo.
naman, nandyan na eh. Okay.
Sinend ko na.
Oo,
Huwag na
magda-download pa kami.
Oo, yan.
Sinend
May
ko
I
na.
speak, Pat?
Ayan, si Ma'am.
Yes,
Dr.
Rima.
Okay po,
Yes, ma'am.
Doktora.
Ma'am Rima.
Dali lang.
Opo, ma'am.
I-type nyo lang Mat plus protocol.
Ma'am,
Lalabas
na-send ko
na
na po.
kagad.
Mat class protocol.
Ah, sige,
Mat plus
Matlas.
COVID protocol. Dali. Nakita ko na eh, oh.
Na-send ko na po sa
Ayan,
inyo.
okay, type daw.
Wag mo na
I-send na
i-download
lang sa
yan.
chat. Naku,
Na-send
alam
ko
mo
na.
naman, madaming...
Na-send ko
Okay,
na sa Viber.
salamat. Salamat.
30 pages.
Okay,
yun.
okay. So, alam nyo, alas 8 na. Pag tayo talaga nag-uusap-usap, hindi matapos. May mga tanong pa sila. But I think
May tanong
the rest
sa'yo.
of the questions,
There's a question
ano
for
ang
you.
tanong sa akin?
Nasaan na ba yun? Teka.
Alin
Si
dyan?
Jimmy.
Nawala na yung ano.
Si Jimmy.
Sa akin ba?
Jimmy.
Hindi kay ano
Si
may
Jimmy
tanong.
kay,
Sorry.
Oo, si
po.
Jimmy may tanong
Dr.
sa'yo.
Fatma para.
Fatma.
Okay.
Tungkol
Sagutin
sa-
natin. Actually, yan ang binabasa ko ngayon dito sa mga journals, no?
Sa RT-PCR.
Meron
yung
silang
tanong.
ginawa. Ang tanong niya is, when is the best recommended time to repeat yung
Yes.
RT-PCR swab of a COVID-positive patient? Nako, ito ang malaking diskusyon. According to the meta-analysis, very few ang mga data on the follow-up because most of the data were done sa swabbing during for diagnosis and yung very few were done as follow-up. However, they said, kasi ang na-require ni WHO dati for discharge, one, dapat subject must be fever-free, no, without fever-reducing medication for 3 consecutive days. Pangalawa daw, subjects must show an improvement in any other symptoms, including reduced coughing, shortness of breathing. At least 7 days have passed since the onset of symptoms. In addition, dapat may 2 negative tests tayo for SARS-CoV virus. However, yung mga nakaraang buwan, di ba tinanggal na yan as requirement for discharge because of the prolonged hospital stay. Ang naging basis lang, basta asymptomatic na for 3 days at lumagpas na dun sa 14 days na symptom from the onset of symptoms, dini-discharge na. So, not many hospitals are repeating the swab. Ang sabi nila, during the first week of post-acute care activity, dun sa mga nag-recover, karamihan positive pa rin talaga. So, bihira na kasi yung pumapayag i-swab, kaya another thing that contributes to the low data. Ang recommendation now, wala akong nakitang na meron ba? Meron ba kayo nagpapa-repeat swab? Pero ako, in our experience here, we do repeat swab before discharge. Lahat sila positive pa rin, pero pinauuwi pa rin sila ng mga infectious at ng pulmon, nag-clear. And then yung mga, I have patients, 5 of them, I repeated swab every 2 weeks kasi gusto talaga nila makakita ng negative. Alam nyo kailan nag-umpisa silang nag-negative? Doon sa 4 na yon na pumapayag na iswab ng iswab. More than 2 months. So I don't know for the rest. Kaya sa ngayon, wala actually recommendation on repeating the swab. Mas tinitest na nila yung antibody after 2 weeks kung meron na siyang antibodies. Ikaw, Marcy.
Hindi, yung recommendation so ang recommendation ng DOH, walang magre-reswab. No?
Walang magre-reswab.
Except for healthcare workers. Gusto nila yung healthcare workers bago pumasok.
Yes, yung pabalik
negative.
sa trabaho.
Kailangan negative. So, ang healthcare workers ang talagang nagpapa-reswab tayo ng ng pa-repeat para maging negative kasi hindi sila pinababalik kung hindi sila negative.
Tapos,
Pero
ang
yan,
question kasi kung
nice,
infectious pa
90 days
siya,
daw.
is still under debate. May mga nagsasabi na basta positive pa rin ang swab, pwede ka kahit wala kang symptoms, post yung hospitalization or post-symptomatic, may mga evidences na pwede ka pang infectious. Kaya siguro yung recommendation sa healthcare workers, kailangan negative ang swab. Pero sa mga patients natin, parang hindi na nagpaparepeat nga si DOH. Pero dun sa mga may pera, na mga private patients namin, nag-uulit kami every 2 weeks kung sila pinapa-swab. Okay, so I think that ends our very nice discussion. Maraming salamat kay Nines for your additional information. Again, as we say, hindi naman po kami expert. Lahat tayo nag-aaral ng sabay-sabay. Para lang tayong nasa classroom na may assign ngayon na siya ang mag-aaral. So kung marami tayong mag-aaral, Nines, aralin mo uli yung next topic ha. Tulungan mo uli kami. And the rest, si Dr. Rima, thank you so much. In behalf of our speakers, meron pa ba tayo? Okay.
Mama Grace is also present.
Mama Grace, maraming salamat po. So, I turn you back to our host.
Sure,
thank you.
Dr. Danny.
Thank you. It was indeed a very productive, fruitful, lahat na magandang positive. Ito yung magandang positive na meron tayo. Wag lang COVID positive. So, thank you sa ating speaker, Dr. Marcy Cruz and si Kuya. And to our resource speaker, si Dr. Nance Bautista. Okay, so maraming salamat sa iyo. So, before we leave, let's watch this ISDCon 2020 invitation. So, and please stay for our photo op. And I'll let you know yung schedule later.
Dear friends and colleagues, the 5th Annual Convention, the ISDCon 2020, and the second Dr. Ricardo E. Fernando Memorial Lecture is going to be held online for the first time. This virtual convention is part of ISD's continuing effort to evolve by using new methods of communication. This year's scientific programs theme is entitled Holistic Diabetes Management Beyond Glucose Control. The ISDCon 2020 features some of the most distinguished experts on diabetes management from both here and abroad. They will share their knowledge and expertise with us on various interests regarding the disease. And we have invited Dr. Richard Bergman, a renowned scientist researcher, to be the second Dr. Ricardo E. Fernando Memorial Lecturer. So on behalf of the organizing committee headed by Dr. Rowena Libet, the Institute for Studies on Diabetes Foundation Incorporated, and its component societies here invite all of you, members of the ISDFI family, to join the first ever online convention. See you all at the ISDCon 2020 from October 22 to 24, from 5 to 9 in the evening. To everyone, stay safe.
Yes, we are ISDFI, providing excellence in diabetic care. Yes, we are ISDFI, breaking boundaries and seeing others' needs.
Okay, thank you everyone. So I'll just flash our schedule for next meeting. It will be on November 7 with our other speaker, Dr. Olive Kison, talking about the BCO, an ally or foe, and I'll be talking about immunonutrition. So with that, I would like to thank our pharmacy and e-grant for this evening. our partners from Merck Incorporated, the makers of your glucophage and glucovans. So huwag niyo po kalimutan sa inyong susunod na pasyente, ito pong glucophage and glucovans. Thank you sa Merck. And please open your videos. Okay, patingin po ng mga mukha ng na-quarantine.
For photo gallery.
Yes. Thank you for attending. Huwag muna kayo umalis. Lynn. Lynn, pa-picture, Lynn. Lynn. Unmute mo na sila, Lynn. Ay, kuya,
Dr.
kamusta dyan?
Ayan.
Pagaling ka po. Lynn. Lynn, magsalita ka naman.
Okay po,
Ano
Doc.
naramdaman? Ready na ba?
Yes po.
Ready? Ready.
1, 2, 3.
Okay. Next. Next screen.
Yes po.
Okay. Next screen. Okay. So, November 7, please mark your calendar. See you po and keep safe. Thank you sa ating mga participants. See you.